Welcome everyone to our 29th seminar of the Centre of Research Excellence in Aphasia Recovery and Rehabilitation seminar series. I'm John Pearce, postdoctoral researcher at the Aphasia CRE and co-facilitator of this seminar series. First of all, we'd like to acknowledge that this event and our participants are located on the lands of many traditional custodians in Australia. Today I'm speaking to you from Bunurong land, and we pay our respects to elders past, present and emerging, and extend this respect to First Nations people joining us online today. Very exciting to be joined today by Professor Linda Worrall, who is going to be presenting on the ASK study. And this is a very large trial, which I'm sure many of you were involved in or came across while it was collecting data. And I hope you're looking forward to hearing what does the ASK study tell us about preventing depression in aphasia. Before I formally introduce Linda, let's briefly cover some housekeeping. Firstly, if you haven't already done so, please join us as a member of the Aphasia CRE community of practice. We welcome people with aphasia and their family and friends, any health professionals, researchers and organisations. Benefits to members include a regular newsletter, updates about events and activities, opportunities to contribute to research, networking opportunities and more. And the CRE is always looking for financial support, so if you wish to donate, please see our website for details. Please note this seminar is being recorded. You can see past webinar videos on our Aphasia CRE website. Just go to the resources tab and there's quite a collection there now, as well as quite a collection of other resources. So if you haven't had a look, I encourage you to do so. Please engage with us on social media via Twitter and Facebook. And if you are on Twitter, feel free to tweet along today with the hashtag Aphasia CRE. If you have questions as you go today, please use the Q&A function on the Zoom toolbar and not the chat function. You can enter your question for Professor Worrall at any time throughout the presentation, and you'll be able to see questions asked by other people. If you think it's a good question, like it or upvote it to show those questions of most interest to the group. Professor Worrall will answer as many questions as time allows at the end of the presentation, and just please ensure the Q&A space is for questions and no other comments, and that the questions aren't too long. And now it's my privilege to introduce someone who probably needs no introduction. Professor Linda Worrall is Professor Emerita of Speech Pathology and the Queensland Aphasia Research Centre at the University of Queensland, Brisbane. She completed her PhD in the Stroke Research Unit in Nottingham and practiced as a speech pathologist in both England and Australia. She founded the support organisation, the Australian Aphasia Association in 2000, and was a founder of Aphasia United, an international peak organisation for aphasia. She's published over 350 peer-reviewed journal articles, including 26 book chapters and 6 books, graduated 30 PhD candidates, and had continuous nationally competitive research funding during her academic career. From 2009 to 2014, she led the NHMRC funded Australia-wide Centre for Clinical Research Excellence in Aphasia Rehabilitation and received the Robin Tavistock Award in 2014. So now, Linda, I'll hand over to you.
Thank you, John. I'm going to share my screen and with the slides, and then we can sort of begin.
Correct.
So firstly, I'd like to acknowledge all of my co-authors on this presentation. Brooke Ryan, who was the postdoc on the project, who really did most of the work, and Marcella Carragher did the covered for Brooke when she was on maternity leave, so Marcella was a postdoc too. We have Ian Kneebone, who's a psychologist, Miranda Rose, Leanne Torr, Emma Power and Nina Simmons-Mackey are all leading aphasiologists and speech pathologists. Tammy Hoffman is an occupational therapist who did her research in secondary stroke prevention, and Asad Khan is our statistician on the project. So I'm hoping to answer the question, what does the ASK study tell us about preventing depression in aphasia? So first of all, we know that we have a problem. We know that depression is common in post-stroke aphasia. In fact, there's a high incidence of post-stroke aphasia, and the Cowan study shows that it's 70% at 3 months and 62% at 12 months post-aphasia. There have been a few studies that have shown that there's a higher incidence of depression in aphasic versus non-aphasic stroke patients. And the Cowan study also showed that major depression increases from 11% to 33%. And that's a bit of a concern. So what was the catalyst for this particular project was a previous NHMRC grant, which was trying to find what were the contributing factors to living well with aphasia. And we followed about 60 people with aphasia at 3 months, 6 months, 9 months, and 12 months. And what we found was that there were some positive factors that factors that contributed positively to living well with aphasia, and then there were some negative factors. In the positive factors, if you had a higher household income, you tended to live better with aphasia. If you had a larger social network, if you were female, if you rated yourself as living successfully with aphasia, so that's sort of indicating a positive attitude. And also if you had less severe aphasia. So they were all positively contributing to living well with aphasia. On the negative side, though, things like higher education, believe it or not, was a negative factor. That is, that if you had a university degree or higher, then it's probable that language was a more important part of your profession and your life, and that aphasia therefore had a greater impact, and that you were struggling to live well with aphasia. Low mood, though, came out as a significant negative factor. And that was a reoccurring theme in several of our studies. And that together with all of those other sort of things like poorer physical functioning as well, that this is sort of the picture of what we can do to help people live well with aphasia. So the modifiable factors in that study were things like, larger social network, a more positive attitude, so that they were rating themselves as living more successfully with aphasia, a less severe aphasia. And also if our physio and OT friends could improve their physical functioning as well, then those people lived better with aphasia. But it was that low mood that I think stood out for me, because we had not really addressed that in our field before. We also know that stepped psychological care for aphasia is a model or a framework of intervention for psychological care. And it's being used in several different areas, but in stroke, it is being used. And in aphasia, Caroline Baker did her systematic review to find out what interventions there were in the literature that showed some benefit to the first 2 levels of stepped care. So let me just go through quickly what stepped care is. So level 1 is level 1 and level 2 is everyone's business. It's level 1 is when someone is possibly at risk for depression, but at the time they are well. So this would include preventative things and would include things like routine assessment, post-stroke psychological information provision, and group support. She also found, Caroline found that in her systematic review that interventions such as biographic narrative therapy, communication partner training, an aphasia choir, self-management workbook, and goal setting had some evidence of keeping people well psychologically post-aphasia. At the level 2, where someone might be beginning to exhibit signs of low mood or sort of sub-threshold depression, then there is evidence of behavioural activation through the CALM study that Shirley Thomas has done, as well as things like psychological education and problem solving. So if the person is having more severe mood problems, then they would be seeing a mental health specialist. And so in level 3 and 4, then those sort of more severe mental health issues would be more intensively treated and by more specialist care. So what we know, therefore, is that there are some therapies or interventions that we can use to hopefully maintain or improve the well-being of people with aphasia. In the meantime, we had both Kyla Brown and Brooke Groan doing their PhDs on what it takes to live well with aphasia. So they found out what the sort of components were really that were contributing to living well with aphasia from a qualitative perspective. Our published study in 2017 was quantitative, and their studies here were predominantly qualitative. Kyla talks about that to live well with aphasia, you need to be doing things, and that the people around you are so important to living well with aphasia, and having a positive approach was agreed by all stakeholders as a vital component to living well with aphasia. Then Brooke Groan took the people with aphasia just in that first year and to see how they learnt to live well with aphasia in that first year. So she tracked them in that first year. And so she found that not only were the same sort of themes came through in terms of a need to do things, social support, and a positive outlook, but in that first year, there needed to be a lot of adjustment going on, and a lot of the people in that first year were talking about the importance of getting enough rehabilitation for their aphasia as well. And they said that was what contributed to them living successfully with aphasia in that first 12 months. So Brooke then sort of took all of that information and made it into an intervention. So she took all of the results of her PhD and Kyla's PhD and our study, and developed this intervention program called the ASK program. And she trialled it in a pilot study with people with aphasia and speech pathologists involved in developing the program and then in evaluating the program. Then that led to this 5-year NHMRC grant that we were successful at obtaining. And the aim of that grant was to determine whether our early preventative intervention leads to better mood and quality of life outcomes for people with aphasia, and less caregiver burden and better mental health for their family members. Because in the pilot study, we found that it was the family members that were particularly positive about the program, the ASK program. So we devised a cluster randomized controlled trial across 20 health districts nationally. And the participants were to receive either their usual care in addition to either the experimental intervention, which was the ASK intervention, or we devised an attention control intervention as well. So the attention control intervention, we needed to make the attention control intervention as meaningful as possible to people with aphasia so that they'd want to do it. They just sort of wouldn't just drop out of the trial. And it needed to be very similar to the ASK program, particularly in the way that it was delivered. So we published our protocol in Trials, and just to go through the two interventions, the experimental intervention or the ASK program, the ASK stands for Action, Success and Knowledge. It's delivered to people with aphasia and their family members, and it's designed to commence before 6 months post-stroke. So that's what we thought of as being relatively early. It's a face-to-face module in one-to-one sessions, and then we did some phone follow-ups after that every month until 12 months post-stroke. The programs were delivered by qualified speech language pathologists, either in the hospital or in the home. And the program the ASK program had several modules. It was aphasia and stroke education. It contained information about basic communication strategies, strategies for managing mood, and strategies for maintaining social network support. Whereas on the attention control arm of the study, we had a very similar type of looking program, but the content was different. So the content was about secondary stroke prevention. And so we had information in that program about stroke, about risk factors, about lifestyle modifications and medications for stroke prevention. And so this was sort of given out in booklet sort of style to the therapist to deliver. So our primary hypotheses were that patients with aphasia who receive the ASK program will have significantly better outcomes on the Stroke and Aphasia Depression Questionnaire, otherwise known as the SAD-Q. There are several versions of it. We used the SAD-Q 21. It's 21 items. And the other primary outcome measure that we used was the Assessment for Living with Aphasia, the ALA. And both of those outcomes were measured at 12 months post-stroke. So the hypothesis was that we would have better outcomes on them from the ASK program participants compared to those who received the attention control of the similarly formatted program of secondary stroke prevention. The secondary hypothesis was that the caregivers of patients with aphasia who receive the ASK program will have significantly better outcomes on the BACUS, Caregiver Outcomes Scale. Most people just call it the BACUS, and the GHQ, General Health Questionnaire, at 12 months post-stroke than those who receive an attention control. So the GHQ measures psychological distress. So the plan of the study was that we would recruit 344 people with aphasia, with 172 in each arm and their family members. And how we planned to do that is that we recruited 20 clusters. So a cluster was a health district. So, and each cluster was requested to recruit 20 people with aphasia and their family member, and to deliver the program to 20 people with aphasia. And most people thought that was pretty easy, that was going to be easy enough. So they signed up for the study. We thought that if some of the participants were receiving psychological care, there was a psychologist on the ward, then there would be different levels of psychological care in urban versus non-urban centres. So we decided to sample the health regions from both urban and non-urban sort of areas. And so we had 5 clusters in urban areas receiving the ASK program, and 5 clusters who were in the non-urban areas receiving the ASK program and the equivalent for the attention control. And so the clusters were randomised to one of the arms of the study. So this is the sort of process through the study, in that once they consented to be part of the study and that they were deemed to be eligible for the study, we had the Before We Begin module, and we then did the baseline assessment, which was before 6 months post-stroke, and then we did the Set Your Goals module, and that needed to be within 14 days of that baseline assessment. And as part of that goal-setting process, they told us what they were wanting from the program and which of the modules in particular they were keen to do. Most of them chose to do all of them. We didn't do it in any particular order. After they finished those modules, which were generally held once a week, the monthly phone calls happened after that, and then we did the assessment at 12 months post-stroke. So the secondary stroke prevention program, the control arm of the study, essentially did the same but different modules. So this is what the module looked like. This is an example of the ASK module called Finding the Positive, which is about having a positive attitude. And you can see that, you know, we tried to do it very much in an aphasia-friendly way. And the therapists involved in the study had training. and they were trained to sort of deliver the program. And there were also therapists that were trained to do the screening part of the study as well. And so you can see there that this sort of booklet is sort of like a guide, if you like, to a discussion guide of what they can talk about. And they were encouraged to sort of discuss these things, and sometimes there was homework as well. So again, the outcome measures that we used at 12 months post-stroke, the person with aphasia completed the assessment for living with aphasia. That's a self-report measure, uses pictographs. The SAD-Q, even though it's about the person with aphasia, is completed by the family member. So it's about their observations of the person with aphasia. We also had a bespoke checklist of stroke prevention behaviours. So because we were interested to see whether their behaviours changed in relation to secondary stroke prevention. The family members completed the BACUS and the GHQ as well. So we included people with aphasia within that first 6 months post-stroke. They were having a first aphasia as a result of stroke, so we weren't taking people, non-stroke aphasic patients, and the usual other sort of criteria of age and hearing and vision. In terms of exclusion criteria, this is important. So these first two are particularly important. So we were wanting to prevent depression from occurring. So we were taking in people who did not have a current psychiatric diagnosis, that is a depressive disorder or an anxiety disorder that was written in the medical record. So they were excluded, but also if they failed the screening with the SAD-Q, which the hospital version, the 10-item hospital version, or if their aphasia was so severe we couldn't get those observations done. The DISCs is the other measure that was used as a screening tool there too. If they were exhibiting depressive symptoms at that stage, then they weren't brought into the study. So, but also, of course, we had the other exclusion criteria of things like other cognitive disorders like dementia, etiologies other than stroke, of course, that they were receiving treatment in a psychiatric setting, and also for the very few who were enrolled in another aphasia or depression clinical treatment trial, they were also excluded. So we were also keen to look at how well this program was delivered by the speech pathologists. So Marcella developed the Fidelity protocol that was published, and there were two sort of components, if you like, of the Fidelity protocol that we used. We wanted to make sure that the content of the intervention was covered by the speech pathologist, but also that the process aspects of delivering the program were optimal as well. Things like that there was rapport building and that there was supported conversation techniques. So this is an example of one of the process aspects of the Fidelity that we looked at. And so the therapist needed to be able to demonstrate the principles of supported conversation. That is, that they were using an appropriate level of communication strategies, things like adapted resources, writing, gesture, drawing, repetition, etc. And that was an essential criteria of the fidelity. It was also an essential criteria that they did the components of the ASK program or the stroke prevention program. And for example, the goal setting approach, that it was there was problem solved with the person with aphasia and their family member, and they set personally relevant goals and, you know, used the quiz responses, for example, in the program to help with that. So what we did was we asked therapists to videotape their sessions, and for their first session, they sent that in, and that goal setting in the first module were reviewed in full according to the criteria in the fidelity protocol. And so we were looking at the video to see if they met that criteria. So if they did, it was all hunky-dory. If they didn't, they were given written feedback and phone coaching, and then they were asked to send in another video of the next session until that adherence and the competence was achieved. And then once they had done it for one participant, they just needed to do one session for any following participant that they were providing the intervention for. So, in terms of the fidelity results, we had 54 therapists who were doing the experimental arm of the study. 46 of those sent in the video for the fidelity check, and there was a 59% pass rate on the goal setting and the delivery of a module, that first exercise, if you like. In the attention control arm, which was the secondary stroke prevention program, we had 30 therapists, and 26 received their fidelity check, and we had a 65% pass rate for the goal setting and delivery of a module. So we were a little bit surprised by those results, and realised at that point that we probably should have included training, particularly in supported conversation, in our training program, but we didn't. So what we did then is Nina Simmons-Mackey looked at some of those videos to see what was happening, if you like. And she looked at people who had passed as well as they hadn't passed, and used what we would call the Kagan scales, the measure of skill in supported conversation, as well as sort of any expected or unexpected things that were happening in those videos. What she found was that in terms of the therapists, that they weren't always using supported conversation skills. That was the main sort of thing that came sort of to her attention, and that some therapists really just read the script verbatim, and perhaps we didn't make it clear enough to the therapist that that was just a guide, you know, that they were to embellish, to discuss, to elaborate on that particular, on the booklet. But she also found that there was some contamination in that the ASK program has things like, you know, what is aphasia, and things like that, and how to keep a positive mood going. And some of those things were being talked about in the secondary stroke prevention program too, in the attention control arm. So perhaps we weren't as clear to people just to sort of not go off topic, which were in the program. So in terms of the number of people that we screened, you'll see we screened a lot of people, or the therapists screened a lot of people. 1,744 people with aphasia were screened across the sites. And it ended up that we excluded 1,513 of those people who were screened. And the reasons for those exclusion generally it's just about not meeting the criteria, and a lot of the times it was because they were not passing the screening, the depression screening, but also often there were other things besides aphasia that that were present. So we randomized 231 people, 113 received the ASK program, and 108 received the experimental program. So we have also done a process evaluation that's still in progress. Emma Power and Brooke are still doing that. And we used the MRC process evaluation framework. So we've done a focus group with the trial managers. We've done a focus group with the key informants from each of the clusters, you know, like the therapists. And we've also done individual interviews with participants from each intervention arm as well. And so the preliminary findings of that process evaluation are things like high staff turnover. So we had some challenges implementing the trial. In fact, we trained over 170 therapists in the trial procedures. So, and this was spread out over the duration of the trial. Because, you know, new people would start in the job, etc. So the focus groups and the interviews show that there's benefit seen in both the interventions, especially, of course, the therapists love the resources, and the participants with aphasia and their family members particularly appreciated the therapeutic relationship with the therapist, so that they had the time to sit down and talk about those sort of things together. There were no harms reported. And we also saw that, you know, site champions were fairly essential to overcoming some of those implementation barriers in doing such a large trial as this. Now to the results. First of all, I'm going to sort of report on the primary outcomes, and this is of structural equation modelling, where we have taken into account the baseline of data of the participants. And we've got, you'll see there, both the intention to treat analysis. That means that you include everybody pretty much who was included in the trial. And then we've got the per protocol analysis. And the per protocol analysis is taking only those people in the trial who completed at least 3 modules of the intervention, that they were delivered the intervention by a therapist who had passed the fidelity, and the other that they had particularly the outcome measurements at pre and post. So what you can see there is there's no significant difference on the self-reported assessment for living with aphasia, but there is a significant difference on the SAD-Q, on the Stroke and Aphasia questionnaire. And this will do your head in, but the results are that not the way that you would expect, that the ASK program was not more significantly better than the stroke prevention program. It was the other way round. So let's just look at the pre and post data, because I think I just find that sort of more meaningful in some ways. And we've got in the experiment, this is the SAD-Q data. In the experimental group, that's the ASK group, they've gone from a mean of 14 depressive behaviours to 13 depressive behaviours. In the attention control group, they've gone from a mean of 12 depressive behaviours to 10 depressive behaviours. So there's been a decrease in both arms of the study. So everybody actually, not everybody, but the means decreased in both arms. But the secondary stroke prevention attention control group had significantly 2.74 lower SAD-Q score than the ASK experimental group, which means that the attention control group had less depressive symptoms at the end than the ASK experimental group. Therefore, our hypotheses were not supported. So we've got a situation where the attention control group had less depression at the end. This is the SAD-Q. So it's a bit fuzzy at parts, but you can see there that the questions that the carer answers are things like question 2, does he or she have weeping spells? Often, sometimes, rarely, never. So what does a 2.74 change? Is it a meaningful change? So it may mean that a person might go from having weeping spells often to never, but it's more likely that they're going to be having changes across these rating scales. So what we did was that I looked at the number of cases with changed SAD-Q scores that were beyond the minimal detectable change. And we tried to calculate this minimal detectable change, but there's not a heck of a lot of data around on the SAD-Q21, which allows us to calculate the standard error of measurement. So the sample size also was not great in the studies that we used. So, but you can see at a glance there that most people in the study showed no change beyond the minimal detectable change of 9.45. There were some people that had a positive change and some people that had a negative change, but the majority were within that range. When we looked at the secondary outcome measures, then we've got the family members' general health questionnaire had a significant result. And so again, but this time it was in the per protocol analysis, but again, it was in favour of the secondary stroke prevention arm of the study. Looking at the means in the experimental group pretty much didn't change. and pretty much in the attention control arm, there was some improvement in psychological distress of the family members, but not a great one. The GHQ, this is again sort of what it looks like, but if you look at item 9 is about being, have you been feeling unhappy or depressed? And then you've got that rating scale of from not at all through to much more than usual. So they're the sort of questions that are asked on the GHQ. So again, the attention control group had significantly 3.60 lower GHQ scores than the ASK experimental group in the per protocol analysis. So this means that the attention control group had less psychological distress than the ASK experimental group. And again, we've got that same sort of picture where most people don't have a particularly positive or negative change beyond the minimal detectable change. So just to summarise, the stroke prevention program, the control arm, was significantly better than the ASK program, the experimental program, as measured by the SAD-Q of the people with aphasia and the general health questionnaire of the family members. But the difference was within that sort of minimal detectable change that we were able to calculate. So it's highly likely not to be meaningful. So I always liken this to, you know, if you have two, let's say, diets, and on one diet you lose 0.05 of a kilogram, and on the other diet you lose 0.025 of a kilogram, the difference is not important, even though one diet might have been significantly better with a lot of people in the trial, but you really, you're not really talking about a meaningful change or a difference between the two diets. So I'm keen to hear your thoughts on this, and to answer the question, does the ASK program prevent depression and improve quality of life in people with aphasia and their caregivers better than the control program? The blunt answer is no. Our process evaluation might help us find out why. We think the stroke prevention program had more active components than anticipated. Stroke prevention is more concrete than abstract things like wellness, depression, etc. And we hadn't realised how much there was of a fear of another stroke that would lead to psychological distress. This study was underpowered. 16 of the 20 clusters didn't recruit the expected 20 participants, and screening and recruitment of this population to us emphasised the extent of depression that already exists in this population. The fidelity of the treatment wasn't strong. We need to be doing better in terms of conversational support, and we had some contamination. We didn't include a usual care group, so we can't say whether the ASK program was better than usual care or whether the stroke prevention program was better than usual care. We can only compare the two programs that were delivered. We also regretted not doing a feasibility study prior to embarking on this very large study that involved a lot of people. On the positive side, both the therapists and the participants liked both the interventions, and we have loaded them up onto the Aphasia CRE website there, and they're free and publicly available. And certainly, I think this trial has contributed to the lessons learnt for future trialists, and we're particularly wondering whether cluster randomised controlled trials are appropriate for complex interventions, particularly seeing the results of Seibenhofer, who said that 85% of cluster randomised controlled trials of complex interventions in GP practices fail to support their hypotheses. So there's something there. So I'm very keen to hear about your thoughts on should the content of both programs be routine in clinical practice, and also just to be aware that there are other options about preventing depression in people with aphasia. For example, home visits by trained peers, and that's the topic of the superb feasibility trial, where you get someone with aphasia to visit someone else with aphasia in their home. That led in that study to an 88% reduction in high psychological distress, and it was seen to be greater than 66% improvement in the cost effectiveness of that sort of intervention. So while you're thinking of your questions, just acknowledging all of these lovely sites all around Australia that participated in this study. Back to you, John.
Thank you, Linda, for taking us through that very complex trial, and thank you for running such a complex trial and for making it easy to understand and doing it quite honestly. So if everyone can enter some questions in the next few minutes, and I'll go through them, but I just wanted to open with one, which is, I don't know how much you kind of digested the results. I mean, to say they're surprising is probably understating it for your investigator team. Do you have a feeling as to whether these results should be taken as read, or do you think that there are perhaps some design things that couldn't be noticed until it was already done, retrospectively picked up?
I would say the latter, John. We thought we'd designed a good study, and we thought we'd got an attention control arm intervention that would be a suitable attention control, but it was way too active. And so I think the being underpowered too, it's always a case for decreasing the trustworthiness of the results. So Katerina, hello Katerina, and she's saying, did the stroke prevention arm lead to greater physical activation? That was one of the items on the bespoke 10-item stroke prevention measure that Tammy Hoffman had developed. So that will be just one item, but there was no significant difference on the 10 items as a whole. So we haven't gone down to that item level, but there was no significant difference on those 10 items that we asked. Ellen, hello Ellen. I know all these people.
Making my job very easy, it's good.
Katerina's in Germany. Ellen is in the USA. Would you want to change your outcome measures? No, I thought the SAD-Q21 held up pretty well, to tell you the truth. What is your sense of its sensitivity to tapping into what you were seeing? I think the GHQ and the SAD-Q, GHQ for the family members and the SAD-Q for that the family members completed on about the people with aphasia were reflecting, I thought, some of the changes, but I'm not sure that we've got a lot of data on the sensitivity to change on those measures, because the assessment and measurement of aphasia, of depression, in aphasia is not easy. It's hard. And I think that we're really at the beginning of developing robust measures that are sensitive to change. We may find that's more in the qualitative side of things, Alan.
I was going to ask about the discs as well, Linda. How many people used that and your sense of that as an outcome measure?
Well, it wasn't an outcome measure. It was a screening measure. So we were trying to screen out people with existing depressive symptoms. So, you know, the discs is only used usually with severe aphasia. It's a very simple measure. You know, I think it's only as good as the therapist who administers it in many ways, because you're going to need a lot of supported conversation to complete the discs. Yeah, so it was just a screening measure. It's not an outcome measure. Right. Genevieve, hello Genevieve in Brisbane. I wonder if there might be benefit in combining the stroke prevention treatment with the ARS treatment for clinical use. I figure that that's what's going to happen. That therapists, many of the therapists said they sort of do a lot of the ASK stuff anyhow, but it's just not in that formalised way that we had it, in that we've got an aphasia-friendly booklet about it. I don't think that stroke prevention is usually part of what speech pathologists do. But I do think that there's the manuals are there, and people and therapists, I think, can judge for themselves whether the family member and the person with aphasia might benefit from some information presented in an aphasia-friendly way about stroke and stroke prevention. Because, I mean, Tammy Hoffman will say that it ends up being no one's responsibility on the stroke unit. So, and maybe speech pathologists need to take on that role for people with aphasia so that they understand stroke prevention. Rajas asks, my question is, the focus on prevention of secondary stroke is better than focusing on ASK. Prevention is better than cure. In other words, in the control arm, the caregivers or person with aphasia were told to focus on their prevention of another stroke than facing the post effect of stroke.
I think the question is the focus on possibly getting depressed versus a positive, preventing a stroke.
Yes.
I think,
yes, and you're right. We're beginning to see in the research on prevention of depression that people really don't want to talk about it, and that it is a negative thing. It's sort of like, here you are trying to say, okay, stay positive, stay positive, stay positive, have a positive attitude, but talking about depression is depressing. So it may be that there's something about depression that people find difficult to talk about, and that it's unimaginable, really, if you haven't had it. So, yeah, is that the answer? I'm not sure.
Yeah, I guess it might give them more of a sense of control, although you talked about strategies for the ASK program as well. So
yeah, I mean, we were really trying to get people to monitor their emotional well-being in that first 12 months. So my feeling is that, you know, that's an important thing to do, and particularly to get the family members monitoring the partner's mental health and vice versa. The family members need to watch their mental health too.
Yeah. Another question, Linda, just from me is, it looked like something like 15% of people you screened were eligible. And I wondered if perhaps people who are more likely to become more severely depressed or depressed for a long period of time are already depressed in that first window where they were being screened, and therefore you kind of inadvertently selected for people who might have had a better result from ASK?
Yeah, I think you're right in that we these people possibly were more resilient in the first instance. You know, they had the support networks around them. They had the family members there. They had they had better coping strategies, etc. So it may have been something that was just, you know, part of their makeup. We tried to include those people who were more borderline, you know, sort of who were at risk of going downhill. And, you know, there are some people that did go downhill. But yeah, these were, I think you're right, the sort of lack of difference between the two interventions is possibly because they were fairly resilient in the first place.
Linda, there's two more questions. Do you have time for those, or should we wrap up?
I do, but if other people need to go, then by all means.
Let's squeeze those in and then we'll finish.
Okay. So Alan,
Alan Bernstein, Alice, go ahead.
You go ahead.
I wonder if a year out you'll see differences between the groups. Perhaps they didn't show immediate impact, but further out some difference in coping, resilience, adjustment may emerge, a delayed impact. Also, were any of the attention control group attending other support groups that may have influenced adjustment?
Yeah, so my instinct, Alan, is that those people who were at 12 months not showing, you know, much, there wasn't much impact of the program at 12 months post-stroke, that from listening to the interviews of participants, that I don't think that's going to change in the following 12 months or 2 years or something like that. The family members, I felt, were the more active part of the couple. So maybe there, you know, if there were beginning to show signs of depression, that the family members would know what to do. But, you know, I think generally, I mean, you might be right, Alan. We might see, you know, after a period of time that there was impact of the program. In terms of whether people in the attention control were going into other support groups, etc., that is a very good question. We have the data, and we can certainly look at that.
Final question from Alison Talmage. I might have pronounced that wrong. Thanks for a great presentation. I'm a New Zealand music therapist, so I'm wondering how adding aphasia choir participation into ASK might help, and whether you had considered this.
Yeah, well, an aphasia choir certainly was one of the parts of an intervention, an effective intervention at the level 1 of the STEP psychological care. And I think there are a range of activities that will help people with aphasia with their mood. A choir or a singing group is one of them. One of my PhD students, Bernadette Matthias, has just finished her PhD, where we didn't find an effect on mood, but but I'm here at an aphasia camp, and my gut feeling is that a choir, it's part of people talking, gathering, social participation. And then the act of singing, I agree, is something that a lot of people find enhances their well-being. Adding it to ask in the community, I think that would be just a fine thing. So I think people can take modules from the ask, and they can use that in a choir setting to explain what aphasia is, about positive attitude, etc. So yeah, the programs are there on the web, and hopefully they will be used in ways that a professional speech pathologist or a music therapist would deem to be appropriate.
Yeah, and clinicians are very good at customizing.
Yes, they are.
So thanks once again, Linda, for the complicated but fascinating study and sharing that with us, and for being very down to earth and honest about it. Stay tuned for our next seminar. We're just finalising that. Keep an eye on our social media channels, and we look forward to seeing you there next month. Thanks very much.
Thank you.